Welcome and thank you for joining the final webinar in the three-part webinar series titled Scaling Up HIV Workforce Capacity for Ending the HIV Epidemic. This series is hosted by NASTAD in partnership with CDC. This series will provide an overview of HIV workforce needs and challenges of health departments and their community partners, and will attempt to address some of those needs and challenges through tools and examples from jurisdictions and community organizations. The series will also address the importance of community representation in the HIV workforce and navigating hiring policies and practices to recruit and hire community members who represent the populations health departments serve. The development and strengthening of the HIV workforce is essential to ending the HIV epidemic or EHE implementation. EHE jurisdictions should address HIV workforce issues through strategies and activities for each of the 4 pillars. In this webinar, we will highlight the importance of community representation in the workforce. In order to meet the goals of EHE, workforce capacity and development strategies and activities should enhance the skills of and promote and support the hiring of individuals representing the communities being served. Presenters will share resources and best practices for building workforce capacity and addressing hiring and HR policies to be more inclusive of people with lived experience and those who are a part of the community being served. This webinar is being recorded and will be posted for future access. Please use the chat or Q&A functions for questions or comments at any time. We hope to have enough time to answer questions after the presentations. If we run short on time, we will compile the questions and send them out with the recording. There's a brief survey at the end of the webinar. Please take a minute to share your feedback. Before we get started, Maria E. Alvarez from CDC will say a few words. Maria?
Thank you, Krupa. How are you?
Doing great, thank you.
All right,
yes,
awesome.
We can hear you.
Great. All right, I'm bouncing in between meetings, so apologies for being a little late. So good day, partners. My name is Maria E. Alvarez, and on behalf of CDC's Division of HIV/AIDS Prevention Program Branch, I'm so pleased to welcome you all to today's webinar. Thank you for joining us today. We really appreciate you taking time out to attend. CDC is excited to continue to collaborate with NASTAD on the final webinar of our current 3-part technical assistance webinar series, Scaling Up HIV Workforce Capacity for Ending the HIV Epidemic. As you're aware, this TA series focuses on addressing the needs and challenges faced by the health departments and community partners as they work to implement the EHE plans. The series, as you know, has highlighted the importance of community representation in the EHE implementation process and the development of the HIV prevention workforce. So a big thank you to today's presenters, the Black AIDS Institute and the Arkansas Department of Health, and Ending the HIV Epidemic Phase 1 jurisdiction. Combined, they will provide strategies on how to develop the skills of community members to provide training and technical assistance to support health departments and efforts locally to provide culturally appropriate HIV prevention services. And we'll also hear shared experiences and practices through a community connected project. We're confident this will be another outstanding webinar. As always, a special thank you to NASTAD for their ongoing efforts in hosting state-of-the-art webinars and to continue to assist our HIV prevention workforce partners and communities. As I always state, if you've missed any of the past TA webinars, please visit NASTAD's website to access recordings and slide decks. CDC remains committed to our ongoing partnerships and the provision of technical assistance services. Thank you again for your participation in today's webinar, and most importantly, for your active efforts to end the HIV epidemic together. Gracias, and back to you, NASTAD.
Thank you, Maria. Our first presenter today will be Maya Merriweather, Project Manager at Black AIDS Institute. It's all yours, Maya.
Right, thank you, Krupa, and thank you, NASTAD, for having me today. My name is Maya Merriweather, as Krupa stated, and I am a Senior Project Manager at the Black AIDS Institute, and I am going to talk to you today about the AAHU model. Krupa, next slide. I'm not seeing the slides move on my end if they've moved.
Sorry about that. Let's see what's happening.
There we go. We can start here. That's just fine. So today's objectives are going to be to discuss the state of HIV among Black Americans. We're going to kind of take a look at where we've been in relation to where we are now. We'll also highlight strategies for addressing HIV disparities among Black Americans. If you could click, oh, there we go. And to explore the African American HIV University model, or AAHU, at BAI and how it serves to address the aforementioned objectives. Next slide, please. All right, so for those who may be unfamiliar with the Black AIDS Institute, we are the only national think and do tank that is Black-led with the stated mission to stop HIV/AIDS in the Black community. And our actual mission statement reads, BI's mission is to stop HIV/AIDS epidemic in Black communities by engaging and mobilizing Black institutions and individuals to confront HIV. So we've been around since 1999, and in the 20 plus years or so that we've existed, we've educated health department staff, educated peer educators and created them as well, community organizations, as well as public health professionals, how to act upon ending the HIV epidemic in Black communities. This work is actually only just a fraction of what BAI does in totality. And if you would like to learn more about our work, we have things such as a clinical services arm and a policy and advocacy shop. You can find out more about that at blackaids.org, or we are at BlackAIDS at all social media platforms, and you can engage with the other programming that we have there. Next slide, please. All right, and to sort of frame why and how we arrived at the AAHU model, I'd like to talk a little bit about the state of HIV among Black Americans. Next slide. So there is some good news to all of this, and that is that today's medicines help to prevent the transmission of HIV as well as reduce its progression. When we think back to the beginning of the epidemic about 40 years ago, we did not have PrEP, we did not have PEP, we did not know about U=U, and we did not have antiretroviral therapy. So these medical advancements have given us these amazing tools that we can help to use to address the HIV epidemic. With medical adherence, for example, many people living with HIV can expect to live lives as long as those who do not live with the virus, and the risk of transmission is often less than 1%, just speaking to U=U, as I'm sure many of you know here. Next slide. So that's the good news. However, there is disproportionality within the HIV epidemic amongst Black Americans. So HIV does continue to be a public health crisis in Black America. Black folks constitute 13% of the US population. However, Black people comprise more than 40% of people living with HIV and more than 40% of new HIV diagnoses. Next slide. So there's also, I wanted to note, disproportionality within subpopulations, even more so, of the Black community. And one point of this disproportionality is how the effects of HIV are especially apparent amongst Black same-gender loving men. And at current rate, we have the stat that approximately 1 of 2 Black, gay, or bisexual men is estimated to acquire HIV during his or their lifetime. Just wanted to uplift at current rate, which means that this is something that we can change and improve upon. Of Black people living with HIV, 85% are aware of their status, but when we look down the HIV care continuum, less than half, 46% are retained in care. So why is this? Like, why does the HIV epidemic look like this in the Black community? Well, Black Americans are uniquely vulnerable to HIV because it's all rooted in decades of structural oppression following centuries of slavery. And this oppression's resulted social and structural issues you're probably familiar with, have probably touched upon in your own work or dealt with in any case, and things such as poverty, anti-Black racism, homophobia, transphobia, misogyny, which leads to things such as housing and food instability, limited educational and employment opportunities and access, as well as a diminished quality of mental and physical health. And we know when people's when all these systemic issues impact someone's health, it's likely because they're causing a great deal of stress, which is a very important indicator and has a very large impact on somebody's health. Next slide. So we know these disparities exist. So what is a way that we can address them? Well, the social determinants of health can kind of guide us in ways in which we can sort of analyze and look at these things. So firstly, we need to think about what drives these disparities. I noted that we have all of these amazing technological and medical advancements that are really important tools in addressing the HIV epidemic, which is true. However, solely focusing on the biomedical advances in prevention and treatment isn't enough to end the HIV epidemic alone, and particularly not in Black communities. There are systems level issues such as neighborhood, such as education, food security, and healthcare that are linked to how long and how well a person lives. So also importantly, with respect to HIV and the disproportionate impact of Black Americans, we have to acknowledge that over 200 years of chattel slavery happened, and in that time period, the American medical institution was sort of built on the backs of these captive African folks who had no agency about, in any part of their lives, including their health. And even after slavery ended and there was already this existing legacy of neglect and mistreatment of Black bodies in healthcare, it was followed by 100 additional years of government policies that restricted access and therefore impacted health. So we saw things such as restricted access to home ownership and wealth, things such as gerrymandering and redlining occurred. And all of these things resulted in a domino effect that has thrown many Black Americans into disproportionate amounts of the negative sides of these social determinants of health, which in turn then results in high rates of negative health outcomes. And of course, that includes HIV. Next slide. So we have all this information, and how has BAI responded to it? Well, BAI launched our We the People report, a Black strategy to end HIV. It was launched in February 2020, and then we launched it again in February 2021 to coincide with National Black HIV/AIDS Awareness Day. So the We the People strategy is comprised of 4 pillars, and I'll just list the pillars here. The first one is to dismantle anti-Black practices, systems, and institutions that endanger the health and well-being of Black people and undermine an effective and equitable response to HIV in Black America. Pillar 2 is to invest in Black communities, and we can do this through resources and services that address the fullness, richness, potential, and expertise of Black people and mitigate social and structural factors that worsen health outcomes in Black communities. The third pillar is to ensure universal access to and robust utilization of healthcare that is high quality, comprehensive, and affordable, as well as culturally and gender affirming. So this particular pillar would enable Black people to live healthy lives in our fullest dignity. And the fourth and final pillar is build. So that means to build the capacity and motivation of Black communities to be the change agents for ending HIV. I believe that this pillar, all of them really, but particularly Pillar 4 embodies to me Alice Walker's saying, "We are the ones we've been waiting for." And then these 4 pillars with the AAHU model, we seek to educate on all of them and also give sort of actionable skills for folks to do these things in their own communities and within their own jurisdictions. Next slide. Okay, so we've arrived at looking at the AAHU model itself. So part of the response is addressed by building the workforce, which the AAHU model does, right? So with the AAHU model, we educate on all 4 of the pillars, and we also work towards achieving them. And just as like a brief tidbit of history on AAHU, this program began in 1999, which is, as you'll recall, the same year that the Black AIDS Institute was founded. And the last official AAHU cohort graduated in 2012. And so a couple years back, we had a transition from our founding CEO to our current president and CEO. And under her, we are really excited to announce that we are relaunching AAHU in 2021, actually fall 2021, so right around the corner. Next slide. Okay, and so here is just sort of a summary of what AAHU is. So I don't know if I've stated it, but AAHU stands for African American HIV University, and it is the Black AIDS Institute's comprehensive training and leadership development initiative, and it is designed to increase knowledge, decrease stigma, and strengthen workforce capacity and engagement, ultimately to address and end the HIV epidemic in Black American communities. Next slide. So the AAHU model is comprised of the 6 sort of branches or schools, colleges, if you will, that you see here. So these include the Science and Treatment College, the Community Mobilization College, the HIV Workforce Certificate Program, the Training and Capacity Building, Outreach and Consultation Shop, Biomedical Research Education, and our AAHU Alumni Network. So looking at the reach and the impact that pieces of this AAHU model have resulted in, is we train about, or we reach about 3,000 people annually across our trainings and webinars. And that's also not even counting the reach of our online informational materials, which we've created nearly 200,000 impressions across all websites and social media. The Science and Treatment College, as well as the Community Mobilization College, will have about 30 scholars per year who will participate in the program. We have, as a part of our training and capacity building shop, brown bag lunch webinars, which are monthly webinars which speak on a topic relating to HIV and also HIV surrounding issues. Over the past year, we've had 772 total attendees for our brown bag lunches. And in addition, we train about 2,000 HIV workers annually through our webinars outside of the brown bag lunches on key HIV related issues and challenges. And so a lot of the items in this AAHU model have been implemented for some time now, and we are really looking forward to adding sort of these newer elements and also the relaunch of some of the elements to reach even more people and build an even more educated and dedicated HIV workforce through this model. Next slide. Okay, so I wanted to sort of highlight 2 of AAHU's flagship programs, the first being the Science and Treatment College and the other being the Community Mobilization College. If you could just click, there's bullet points on this slide. All right, so the Science and Treatment College and Community Mobilization College are comprised of year-long cohorts to develop and build the capacity of the workforce. The content will be delivered in a hybrid, meaning synchronous and asynchronous manner. So part of it will be at your own pace, and the other part will be with the cohort and on a schedule. Scholars will meet, and this sort of looks like scholars meeting virtually at the beginning of and the end of each module. There will additionally be an orientation and initial coursework for the module and group discussion. There will be some time in which we'll spend synthesizing module information, having Q&As, and also minting learning checkpoints to make sure that folks are not falling behind in the course and that they are absorbing the information. The asynchronous materials will include things such as didactic sessions given by BAI staff, as well as the faculty on our scientific advisory committee. The asynchronous portions will have an element of individual assignments for completion and submission by the end of the module term. There will also be bi-weekly discussion board prompts for group learning. So you're not only learning from the experts that BAI has appointed, but you're also learning from your peers. Click, there's like 3 more bullet points. Thank you. All right, so there's also graduation outcomes that the program culminates in. So the scholars will design and present a brief program plan for a community HIV prevention initiative, as well as they will design and present a brief needs assessment and detailed logic model for a community mobilization around an HIV-related issue. And so this graduation outcome serves to create an opportunity for folks to apply all of the knowledge that they've just learned in a manner that is specific to them and specific to their locale. Next slide. And just to overview some of the curriculum that you can expect in each of these colleges, the Science and Treatment College will be comprised of 4 of these modules. So one being the foundational knowledge of science and treatment relating to HIV. There's a module on HIV and public health. The 3rd module will be HIV pathology, prevention, and treatment. And the 4th will be leadership development and capacity building. The Community Mobilization College will be comprised of modules including HIV/AIDS in Black America, community mobilization, and then creating the needs assessments and logic modeling, which we will, of course, teach you how to do, but also give you an opportunity to build it something specific to your community. And sort of to sum it up, what these colleges seek to teach, the Science and Treatment College is science focused, and you can think of the Community Mobilization College as being grassroots organizing focused. Next slide. And so, as I said, we are relaunching right now. We are very much in the process of relaunching it. And so there's some opportunities for if you would like to enroll for you to do so now. So we are underway with our pilot of the HIV certificate program. And what that program is a self-guided, completely virtual learning platform or experience, which we are training the HIV workforce on select topics that we've identified capacity needs around. It's about 10 to 20 hours of learning, and we say, I know that's a fairly wide range, but truly it is dependent upon your relationship to sort of test taking and just your general pace of learning. But our pilot is underway now, and so if you would like to participate, I'll have my contact information on in the next few slides, and we can get you enrolled in the pilot. We are immensely grateful for any feedback which you would be providing us in the pilot, so that when we launch the program in September, it will fully address all of the needs and feedback that you will have provided us. So it'll be an even better program than it currently is. The Science and Treatment College and Community Mobilization College are accepting applications now for the inaugural cohort. If you are on BAI's listserv or email list, then you've probably seen the email blast about how to apply. And if you are not, you can subscribe to receive BAI email updates at blackaids.org, or you can reach out to Tanisha Lewis, whose contact info you will see shortly, who is our Senior Training and Capacity Building Manager, and she can connect you to the application process so that you can enroll in the fall. Next slide. So I just wanted to highlight here some of the training and capacity building services that BAI does provide. So we are able to, if you would like, provide you with facilitation services, and we can do this for organizations, for health departments, and just for communities who are looking forward to working through a different topic, and also to create plans of action for that. So we have those on the topics listed here. We also offer technical assistance, so any assistance in various aspects of planning and engagement process within communities, we offer that as well. We can also work with you to sort of create a training plan to sort of tailor it to your exact organizational needs. Next slide. And then, of course, we also, in addition, offer trainings on any of the topics you see here. So I know this font's pretty small, but you can just go to blackaids.org and find our training and capacity building page to see in detail what our offerings are. And like I stated, we are happy to work with you if you want to cover a topic that you don't see here, or if you'd like to combine certain things that are listed here, just so we are fully addressing your organizational needs. Next slide. And I just wanted to recap what we talked about today in the form of a wrap up and takeaway. So next slide. So what I'd like for you all to remember is that Black Americans are impacted disproportionately by HIV, and the disproportionality even exists more in subpopulations of Black Americans, such as same-gender loving men and transgender women. Also, social and structural efforts must accompany biomedicine or biomedical interventions. I'd also like for you to remember that BAI connects with stakeholders, partners, trains community members, and builds workforce capacity with its We the People strategy, as well as its AAHU model. Next. The application is open for the HIV certificate program pilot. Next. Wait. And the AAHU cohorts applications are available summer 2021, aka right now. And the last point is that training and capacity building consultations are available for EHE funded jurisdictions, health departments, and community organizations. Next slide. All right, and so as I stated, you can reach out to, in order to get enrolled into the AAHU Science Treatment College and Community Mobilization College by reaching out to our Senior Training and Capacity Building Manager, Tanisha Lewis. Her contact information is there. It's just her first name and last initial at blackaids.org. You can also reach out to me if you would like to enroll in the HIV certificate program pilot. And again, my name is Maya. M's my last initial at blackaids.org is where you can find us. And also you can follow us on social media. And so that concludes what I have to talk to you about today. Thank you for listening.
Thank you so much, Maya. Really great presentation, some great resources. I hope we'll get some questions. Please feel free to put in your questions for Maya into the chat or the Q&A feature, and we will get to all questions at the end of our next presentation. Our next presenters are Kevin Holmes, LGBTQIA+ Outreach Coordinator, and Los Santos Woodley, Community Connector for the Central Region, both from the Arkansas Department of Health. Kevin?
I wonder if he's on. Okay, yeah, there you go.
Okay, thank you for introducing us. We're very happy to be here today. We're going to talk to you a little bit about a program that we launched a couple of years ago to address the gaps in services as it related to those who are disproportionately affected by HIV here in the state of Arkansas. Next slide. So the objectives for today are the history of the Community Connectors program, the structure of the program, successes and challenges, best practices, and then Los Antos is going to talk more about the day-to-day functions as a connector, the pros and cons of the program, and then suggestions for recruitment. Next slide. And so the Community Connector program is an initiative developed by the Arkansas Department of Health's HIV prevention program to address the gaps in prevention, HIV services, and outreach to those who are disproportionately affected by HIV and AIDS in the state of Arkansas. The goal is to provide support services that would advance HIV testing while identifying linkage to care gaps and resources. This innovative approach allows individual contractors the ability to access HIV prevention funds. Priority populations for this initiative are GBM, which is gay and bisexual men, transgender women of color, African American women, and those who inject or use drugs. Next slide. So the structure of the Community Connectors. The Community Connectors cover the 5 regions of the state, which are Northwest, Northeast, Southwest, Central, and Southeast. Community Connectors are contracted through a $10,000 memorandum of agreement with the state. If needed, an additional $5,000 can be added to their contracts as needed with a maximum of $20,000 per contract. All of our Community Connectors go through our voluntary testing and counseling training, which allows them to provide rapid screenings throughout the state. Community Connectors receive technical assistance and capacity building throughout the year from the state. We provide them with everything that they need, and we also suggest different things like webinars and other trainings that they can go to that we may not actually provide here. So again, prevention efforts include linkage to care, rapid HIV screenings, PrEP referrals and navigation, support groups, HIV one-on-one presentations and education, and collaboration and partnerships with local organizations such as Boys and Girls Clubs, colleges and universities, and LGBTQIA+ led groups. Next slide. So if you look at this, I don't know if you can see this. I tried my best to kind of blow it up a little bit so you guys could see it. So as of right now, we have 5 community connectors within the state, and they all have a target population. And so Connie is in our southeast region, which actually has a large portion of our African American community. And so her target population is African American women. Los Antos, who's on the call with me today, has our central region, and his population is young GBM with emphasis on Black GBM. So Keith Jones is in the central region as well, and his target population is GBM 35 and older. We do have a vacancy in the Northeast Arkansas that we're trying to actually get filled, but it's kind of hard in that area. So I'll talk a little bit more about that a little bit later. So Michael Burks is actually in our Northwest Arkansas. So his population is HIV positive persons. And so he works specifically with those who are already HIV positive to ensure that they are undetectable, or to ensure that they get to an undetectable status by providing them with support groups and other prevention services. Tanya Estelle is in our Southwest region, whose population is transgender persons and those who inject and or use drugs. And so we have a variety of different community connectors who do different things to reach the populations that we serve and those who are disproportionately affected. Next slide. So some successes and challenges, and if I'm going too fast, somebody can please let me know. I like slides, but I do like to talk off the cuff as well. So some of the successes and challenges of the program, clients are getting confirmation testing done or scheduled the same day as their screening. So because our community connectors work on an individual level, especially when they're doing testing, they can actually take someone to their confirmation testing after they had a rapid screening that is a preliminary positive. And so we feel like this is a win-win for all. Sometimes clients go to big testing events, maybe like on a Saturday or a Friday night, and they can't get into the clinic until Monday. But our community connectors actually work throughout the week. We have community connectors who partner with Walgreens and other organizations to do testing throughout the week so that people can actually get their confirmation testing the same day or the next day. Innovation within the program on how to reach populations, such as events like Pillow Talk, where Connie Roebuck provides sex education to Black women in rural Arkansas in an intimate setting versus clinical. She actually came to me with this, and I was kind of apprehensive about actually approving it, but it has actually been a successful event. She actually provides HIV testing there as well. She does condom demonstrations and other prevention services as well. So testing has been provided in non-traditional settings, such as bookstores, sex shops, and Walgreens. And we talked a little bit about that earlier. We've actually partnered with Walgreens for years through the Greater Than AIDS campaign, and we actually just kept that relationship going afterwards. So community connector retreats for those living with HIV have been a huge success in retaining people in care and providing support to those who are newly diagnosed. I have a quick kind of story about that. I went to Michael Burks, who does these type of events. There was a young man there who was on a walker who had an AIDS diagnosis and was literally, I mean, his legs were like gnarled and like they looked like tree limbs, and he was on a walker. That was his first time ever in any setting where he saw other people who were HIV positive. So we didn't know that he was going to make it. And so throughout the year, I was calling and checking to see how he was doing, and they really didn't know his progress or didn't really know how it was going to pan out. But the next year, I went to the event. He tapped me on the shoulder and jumped into the pool. And so for me, that was a huge success because he had that support system at the retreat, where he may have not gotten that anywhere else. So some of the challenges, innovation may be stiffed by the restrictions of the agreement. We all know that we have HIV funding, however, it is funneled through our Arkansas Department of Health, and sometimes with us being a rural state and a very conservative state, sometimes innovation can be stifled by some of the things that they bring to the table that they may want to do that may be within their scope of work, but may not be approved through the Department of Health. One of the other challenges is paperwork overload, which can lead to a lack of effort due to more outreach and prevention work. There is a lot of paperwork that goes into it. You have to sign your MOAs, you have to sign 4 or 5 different forms. And then you also have to record your daily activities throughout the month. And I think Los Angeles is going to talk a little bit more about that in his presentation. Another challenge that we may have or encounter is new management can sometimes mean new rules and regulations. So sometimes when we have new management that comes in, that's, I guess, above me, they tend to change things and kind of regulate things to their liking. And so sometimes that can be a challenge to some of our community connectors who have been doing the work for years and may already have a constant flow, and then they have to kind of change what they're actually doing throughout the year. Next slide. So best practices, and I think this is actually my last slide. Wow, I got through these pretty quick. So best practices, for us, by us. Okay, I always live by this mantra: hire those within the population you are trying to reach. I always say that populations are not hard to reach. You just have to have the correct people to reach them, which is usually their peers. Show your support to the community without an agenda. This is very important during Pride season, when you may normally want to just go and do testing because there's a captive audience. You may just want to go there to kind of scope out maybe potential community connectors or whatever program you actually want to do. So innovation, within reason, allow for non-traditional outreach. That's why we have allowed for the pillow talk to happen. We've allowed for other events to happen. And Los Angeles is going to talk about one of his events that he's doing right now with young Black MSM that I think is really, really innovative. So another thing, because these are contractors, do not base selections on formal education. Go by passion and lived experiences. Provide them with the tools they need to be successful. And that's what we do with this particular program. Anything that they need, we make sure that they have it so that they're set up for success. Whatever paperwork they need, whatever, if I need to go to one of their events and do the testing while they actually run the event, I'll do that. We also have them to partner with other community-based organizations who have funding with us as well to kind of maximize effort. Look for those who are already doing the work, but may want to have a broader reach in their efforts. Look for that bubbly person who's already doing the work, who has a wonderful personality, because this work really is about finding people who are passionate about the work that they do. Next slide. So the day-to-day functions of a community connector. So community connectors predominantly operate off a 30-day calendar that was required before the beginning of the month of service. So what we do is we require them to put in a 30-day calendar 10 days before the next month. So the 20th of May, their calendar is due for June. And the reason why I do that is because I want to make sure that everything that's on their calendar can be pre-approved, so they're not doing anything that they won't get reimbursed for, and this is a reimbursable grant. So the calendars detail exactly what the community connector has done, scheduled on that particular day. So this is where we talk about the paperwork. There's a lot that goes into it, but we just want to make sure that everybody is held accountable, including myself. Activities can range from HIV testing, HIV/AIDS counseling, condom distribution, STD awareness classes, or assistance with linkage to care. We also do PrEP referrals as well, and I didn't put that on there. Believe it or not, Arkansas is just now kind of coming into the fold as it relates to PrEP in general. And so our community connectors are doing more with PrEP referrals. Many days are filled with educational opportunities for both friends and family. Again, they work on a very individual level. We don't require them to actually work certain days. It's just according to what they can actually work. And sometimes
that was my fault, Kevin. I was unable to get unmuted. Would you like for me to continue?
Yeah, that's fine.
Sorry, you guys. I was trying to get in to actually be able to speak, but unfortunately, I was having a little issue. But as I was introduced, my name is LA, and I take pride in saying I'm one of the youngest community connectors here in Arkansas right now. And I've always been intuitive in doing these things, so it's just great to have the opportunity to do it and get paid for it. So leaving off or starting off where Kevin had left off, the calendars. So due to the fact that I know he mentioned earlier that we're kind of unbiased, like with our work, we kind of have a lot more leash room and leeway than they do as actual employees at the Department of Health. The calendars, it's an awesome ability to be able to tell people like what you're going to be doing or what you plan to be doing for the month. And they do name out our day-to-day services. It's how we let people know like what we're doing to get paid or what we're doing to make the job that we're actually doing fruitful. They can be kind of tedious because I can make plans with someone to meet to provide condoms or some type of service, and things don't always happen that way, whether or not somebody cancels or they get cold feet and they don't want to link up or they don't have a ride and I'm not going, I don't, with COVID and stuff, I normally don't try to go to people's homes. So if we can meet in public, that's fine. But the calendar can be kind of tricky, but it's an awesome way in order to let yourself know how much work you're doing during the month, and as well as the people that you're working with, let them know the progress that you're making in the community. As it lists, activities can range from HIV testing, HIV and AIDS counseling, condom distribution, STD awareness classes, or assistance to linkage to care. So I currently have this group that meets once a week. We normally try to meet on Fridays or Saturdays so we can have a few cocktails. But it's called the Bow-Legged Chronicles. So basically, me and a group of other men that are between the ages of 24 and about 35 meet up. Sometimes at my home, but majority of the time it's in public, so we can actually talk about some of the current topics that are going on in our community. They also are, tasked with bringing people with them, at least one person, someone that you might know that's not getting tested or that is HIV positive. They can kind of give us a outlook, on kind of what's going on. So I've been doing that since the beginning, actually. And it's actually been pretty fruitful. You gain a trust and a bond with these people, and they trust you, and they're able to dictate that trust by telling other people they can trust you. So that's kind of my form work for that. I did list that many days are filled with educational opportunities for both friends and family. I'm not gonna lie to you guys. I have educated so many people in my vicinity, especially my siblings who are younger, much younger than me, and my family. The condoms that the health department provides to me, I'm like the condom man. Everybody always comes to my house to ask me, hey, you got some condoms? Or they're on Facebook or Twitter messaging me asking me for condoms. One of the biggest things that I want to provide in the future, if I can kind of slip this in for us, is the ability to provide more than just condoms. Because we do have the ability to provide them, but I'm not really connected outwardly nationwide with people to be able to get distribution of items like lube or things that they don't provide to us. So next slide, please. All right. So that's one of the things I was just speaking into. So the pros and cons of being a community connector. We do have the freedom to express our own educated opinions freely without the risk of having someone look down at us or tell us that, oh, you can't say that. It allows us to do a lot more with my particular target group as a connector. I'm talking to people that are my age. I'm a millennial, so I'm talking about Generation Z people, and everybody that comes after that is so hard to like. I'm a little older than what I used to be, but being younger gives me the ability to touch people that way that I wouldn't be able to do if I was actually an employee for the Department of Health. So it kind of like, what is it called? Like red tape. It kind of cuts the red tape for us. We do have the ability to get paid for bettering the community and assisting others with their sexual health. Growing up, I'm not originally from Arkansas. I moved to Arkansas when I started college at 17. And so I'm a city boy. I'm from Detroit, Michigan. So it's like things move a lot faster there than they did here. People kind of like operated in circles, and it was kind of like us, it was a slower, more, peaceful type of city. So being here, I've always helped people. I've always wanted to help people. Kevin got me involved when I was really young in college. And so I've always been a part. I've always wanted to teach others and preach sexual health because, at one point I just got tired of being the only guy in my friend group who was not positive. And it's not that I was craving to be HIV positive. They were just all so dumb about it. They didn't know anything. Everybody had the ability to learn these things or to start taking medication, and nobody was taking advantage of it until it got too late. And I strive to continue to do this work in the city with everyone's sexual health because I want people to know that you don't have to die. It's not 1979. It's not the 80s anymore. If you do go, it's because you chose to. You know what I'm saying? And people don't like to hear that. And I feel I feel like sometimes it needs to be said, especially to people my age, because we don't know. You don't know how bad it hurts to lose a finger until you actually lose one. So lack of materials due to what the health department can provide by state standards. That just goes right back into what I was mentioning about being able to collect items. I understand I've been out of pocket. I've given money, to people in order to provide condoms and lube if I can't provide what they actually need. but I'm not rich by far, so that kind of wears out, you know. But I understand when people need it, if they asking for it, that means that they need it. So I'm willing to do what I can to help. But just we have that. There are certain things that we can't provide. You know, I won't go into detail into all of that, but majority of the time is just having the equipment to still be able to give people the option or the ability to have safe sex if they don't have the equipment to do so. And last but not least, just access to firsthand knowledge on HIV and STD statistics. Kevin gets up, I'm sure, every day he go to work and they have this big meeting talking about what the statistics are from Arkansas, and then it trickles down from there. So always being able to tell people if we have like a gonorrhea outbreak or if we have a syphilis outbreak, which directly leads to, you know, new cases in HIV and AIDS. It's like having that knowledge, I'm able to put that on my social media, or I'm able to, you know, reach out to people in a casual conversation, mention that we currently have a syphilis outbreak. So please make sure you're wrapping it up. You know what I'm saying? So that's the end of my slides. You can go to the next one. I think I have one that says suggestions for recruitment, but that basically was just going into, if I know in the chat, if we're still here, if any of you have any suggestions on how I can better myself as a connector for recruitment outside of the, I'm not really looking to recruit any other connectors. I know Kevin would like that, but the ones that we have, we all do a wonderful job, and we're all put into this task. Like when we signed up to be a connector before they chose us, they asked us, what is your goal? What are you going to do when you get hired? Like, what are you going to be doing? That gives you the room to be able to say what your goals are, what your ultimate goal is, and what you can do during that time in order to better the community. It's a really, really great program to me. There are some things that I will quirk, but it's for right now, if this is what I have to do in order to benefit my community, I will. So like I said, if any of you guys have any suggestions on recruitment for people who will be interested to help, please send it in the chat and we can go from there. I hope all of y'all have a good day from here too.
Thank you so much, Los Santos. Thank you, Kevin. Really great presentation and a really great program. We have a lot of questions in the Q&A, so we'll go ahead and move on to our Q&A. Please continue to send in your questions. I'll go ahead and start us off. Our first question is for Maya. Some health departments won't allow their staff to participate in BAI's Workforce Certificate Pilot Program, saying it should be open to all staff and not just Black professionals. What would your response be to them?
Actually, it is open to all professionals. So all who want to take it completely can. Although it is open to everyone, and that is not going to change. I think maybe the misinformation is that it is a Black-centered curriculum. So everything that we have created is created to center the experience of Black folks as it relates to HIV. But no, it's for everyone.
Great, thank you for that clarification. Getting some other comments, which I'll put into the chat. We also have a few questions that are just general questions. I'll share one and see if any of our speakers are able to give their thoughts. Given that full-time workforce support represents more than half of all expenditures on average, what are ways that we can monitor and plan for solid gap areas in our health workforce over time? What structure do we need to look at current and future demands to project how we need to invest to recruit and retain?
Do you mind repeating the first part of that question?
Sure. So given the full-time workforce support, given that full-time workforce support represents more than half of all expenditures, so salaries, fee for service, things like that, what are ways that we can monitor and plan for solid gap areas in our health workforce over time. What I can do is ask folks to unmute and if they want to ask this, the person who asked this question, if you want to unmute and maybe clarify your question.
I mean, I can try to answer it to the best of my understanding. I would suggest that, you know, doing a needs assessment or a gap analysis sort of tells you a lot about what you have and what you need, and also just how things are sort of being utilized. I think that's a really great place to start, is just sort of being honest about what you need to do, what you want to do. I hope I addressed your question, at least in part.
Thank you. I would like to ask Maya, can you talk more about the pilot program? You mentioned that it is open to anyone. Who would you say is an ideal candidate, or who do you recommend health departments can refer to the program?
Sure. So an ideal candidate, so the program was kind of designed with the entire HIV workforce in mind. So that is anyone from provider to like health education specialists. A lot of the topics are sort of adjacent to, although it also does include sort of like HIV science and sort of that technical education. I think it's going to be new to everyone because it does center Black folks and the health disparities that we've talked about throughout this presentation. So I would say that the ideal candidate is someone who engages with the Black community a lot in their HIV programming, who maybe is part of a jurisdiction where there is a large population of Black folks, and just people in general who are dealing with marginalized populations even outside of Black people. I think that this program really serves to build knowledge around that, and that is in particular where this program shines. And like I said, that the curriculum of the program is not limited to just that. We also talk about topics such as mental health. You'll learn about HIV science in depth, such as the HIV drug classes and transmission of HIV and things of that nature. So it really covers a wide range of topics.
Great, thank you. This question is for Kevin. Can you talk a little bit about how is the Community Connector program funded? One of the biggest challenges that health departments face in terms of hiring under the traditional requirements or HR policies is you know, folks who may have lived experience but don't meet the requirements that are on the job description. So how do you all go around that? What kind of funding is used to fund this program?
Okay. So our money actually comes from our HIV prevention program, and actually comes from our PS 1802 funding. It was written by our former HIV prevention manager and the LGBT coordinator who was actually before me. So it is actually our HIV prevention funding that we actually use.
Great, thank you so much.
Mm-hmm.
And do you have any suggestions, recommendations for health departments that would like to set up similar programs in terms of how to navigate hiring policies or funding restrictions to ensure that they're recruiting and hiring people from the communities that they serve?
Yeah, so what we did is we looked at people who came to our HIV prevention planning group meeting. They were all the community connectors that were actually chosen are actually chosen. So we reach out to them. And then sometimes they help us recruit other people who are part of the program. And since it's a memorandum of agreement and not an actual grant that they have to actually sign, that's how we kind of get away with it. We do a memorandum of agreement with them. So they sort of act as business associates through the health department, and then they only get up to $20,000. So from what I understand, $20,000 is what can be allotted before it actually turns into something that requires a lot of other information and a lot of other requirements. So our community-based organizations get funded at the level of 25,000 all the way up to about 60 to 70,000. But this contract is only for up to $20,000, and most of our community connectors only use about 10,000 of it because they have other jobs. But we can fund them up to $20,000 through a memorandum of agreement instead of a grant application.
Which means that we can work as much as we want as long as we, are working basically. So say I didn't have the ability to get as many hours at my full-time job as I would as working as a connector. I could utilize all of that time furnishing my community or responding on social media or doing things, and I would still get paid. Sorry, Kevin, I didn't mean to cut you off.
Oh no, you're fine. Yeah, that's perfectly fine. Yeah.
Yes, and Los Santos, are you able to talk about, can you share, how did you become involved with the health department, and what was your, if you don't mind sharing, what was your view on the health department? We have, obviously folks from the community. Sometimes there's some history with health departments, and so the relationship may not be so great. So just wanted to kind of get your perspective on what health department, first your experience, and then what can health departments do to kind of break down that mistrust and engage the community.
Yeah, I can answer that. Um, I'm 28 years old, and like I said, I've been in advocacy since I was 17. When I started at college, man, I like I said, I was introduced into advocacy through Kevin. He gave me the opportunity to work with NASTAD several times while I was in college. I think we flew out, we flew to DC for a conference with NASTAD, and I fell in love. Like I had always had friends that were positive, but as far as in advocating for them and being able to help them in the best way that I could, that was kind of how I got into it. It led for me to get national coverage because I created a gay straight alliance on my college campus, and it was so controversial because I went to a private Methodist college, so it was like we're there, but nobody's really talking about sexual health. Nobody's talking about the STDs that are going around campus. It's all like hush hush, and the nurses like providing people condoms. And so the thing was, I ended up getting an STD while I was in college, and my experience with the nurse there was very like she was shaming me. Like you need to be careful. You shouldn't be having unprotected sex. You're gonna catch HIV, and then what? And I was looking at this woman like, can you just write me a referral so I can go? Like, and then when I did that, I realized that even I have a strong personality. I wasn't shamed. I knew what I was doing, but the fact that this medical professional was shaming me as a gay man because I was having unprotected sex made me feel horrible. And so that kind of like empowered me to continue to do these things. So we implemented like a sex week and all of that. But that's how I got into advocacy. I blame Kevin. But blame is a bad word. It's just so much. It's more work than what I ever could have imagined. And I'm capable of doing it. You just got to reach out to the right people. So going into how I feel about the health department, for professional reasons, I'll reserve my honest comments just to say that I feel like they could do, I feel like they have the ability to do so much more. But as I've said, I've only been employed by the health department for the past 8-9 months, but I've worked with them on projects, personal and private, outside of me being a connector, and they're always willing to help. But there are some really, really, really big distances that we have compared to other locations when it comes to what they will provide or what they will allow money to be spent on. And I know it's for purposes unknown because, like I said, I'm not an actual employee for the department, but there's a lot of, we can't provide that, we can't give you that, we can't pay for that, we can't take care of that, you have to let us know about this, otherwise we won't be able to do this. So a lot of the times, to be completely honest, before I contact the Department of Health when it comes, or before I contact Kevin or Kevin's boss or anything about, getting things taken care of or reimbursed, I'll just pay for it. I just take care of it on my own because it discourages me in a sense. Not that I know that, I'm not afraid to ask for it. It's just always that I don't want to ask for something and then be told no and still have to take care of it anyway. So outside of that, they're very open. It's emails. Everybody wants to make sure that everybody's included, and that's great, at our Department of Health. It's awesome. I can just pop up and go up there and everybody will let me on the floor and we'll talk and we'll brainstorm. But outside of that, one of the biggest things that I want our health department to work on and that I'm striving with Kevin to work on is what we can provide. I hope that answered the question.
Yes, thank you. Thank you for being so honest and open. We have one final question, which is for Maya. Maya, can you talk about the training and capacity building consultation services that BAI offers in terms of what have you seen works well for health departments, things that health departments could take advantage of, particularly those health departments that may have challenges with engaging the community or maybe are new to ending the HIV epidemic, EHE?
Sure. So I think the best way to answer your question is honestly that it really starts with like a needs assessment for the health department. So it's really examining where your capacity building needs are and then creating a program that is tailored to you. I think this has worked in the past with, we've had really great success with health departments who need capacity building or technical assistance around their PrEP programming. So there's, maybe a disparity in certain subpopulations of Black folks, let's say, who are not accessing PrEP like they would like to see. And so a lot of the capacity building we've done around that has been a great success. We also had a really successful training on people first language that a health department identified. And I think sort of the basis of all of these trainings is we start with the state of HIV in Black America. So we really delve into the health disparity and the epidemic. And I think just sort of level setting around that is what helps all of our then uniquely tailored programming to be successful. So, yeah.
Excellent. Thank you so much. And we'll be sharing these slides with contact information for all three presenters today. So for folks who have questions that they may think of later or don't feel comfortable asking in this format, please do reach out. Thank you again to CDC and to today's presenters and participants for joining the webinar. The recording of this webinar will be sent out within the next 2 weeks. As a reminder, NASTAD and CDC's Ending the HIV Epidemic Implementation Technical Assistance Meeting will be taking place August 3rd through the 5th. This meeting is for EHE Phase 1 jurisdictions, both health departments and community. Health departments should share registration information with community leaders from your EHE advisory boards, planning councils, and any others instrumental in EHE planning and implementation. Registration is open until July the 30th, and we have put in the link for the registration in the chat. Please do register if you haven't already. Again, here is the contact information for our presenters. And in addition, we've included information on how to request capacity building assistance or technical assistance through CDC, through NASTAD, as well as our TA partners. We thank you for joining today. When this webinar ends, you'll be guided to the post-webinar survey. Please take a minute to complete this brief survey. It's only 3 questions. We greatly appreciate all of your feedback. Thank you again, and enjoy the rest of your day.